Okay, guys, let's finish this up. So if you have a patient who has microcytic anemia, this is someone that's, that we just talked about that is less than 80. So in order to determine whether it's iron deficiency or thalassemia, remember in time is only micro, then we need to look at our RDW. We need to look at and order a TIBC, ferritin and serum iron. Remember that iron, we have to get a ferritin level, Fe, iron, in order to do an iron, or to rule in iron deficiency anemia. We have to get a level. Now, if that level is normal, then we're looking at thalassemia. But if that iron, completely lost train there. If that level of ferritin is low, then we're looking at iron deficiency anemia. Okay, so let's get into musculoskeletal, guys. We're going to try to wrap this all up in an hour. We got a little bit more to go over, and I'm going to try and make it pretty fast because I've already went into well over 3 hours. So let's go into musculoskeletal. So we need to talk about a navicular fracture. Okay, so this is a patient who comes in, and the case scenario may simply be that they fell and they put their hands down, and when they did, this is hurting. Okay, you do an X-ray and it's negative. Now, the one thing about a navicular fracture is that it can be not show up on the first exam because of swelling and bruising. So if that patient or that case scenario says that a patient comes back 2 weeks later and it's still hurting, we need to repeat that X-ray. Okay, repeat the X-ray if it's been 2 weeks and they're still having pain. We also need to know that we need to put it in a thumb spigot cast. You need to know this, hint, hint. And refer that patient. Now, let's say that you have, we're just in the musculoskeletal. You have a patient who was in a multi-vehicle accident, and hours later they have uncontrolled, involuntary, uncontrolled, well, let's just use the word involuntary because that's what they'll say. Involuntary loss of urine and bowel. We need to be looking at cauda equina syndrome. And this is a medical emergency. We've got to get them to the hospital, and we've got to get that decompressed. Okay? So involuntary loss of urine and bowel, we need to be looking at cauda equina syndrome, and we have to refer for a decompress immediately. If you have a patient who comes in and they talk about a low back pain, make sure that when you're talking about that low back pain, or they're talking about this low back pain, if it is sudden, and kind of probe them along. And in the scenario, they talk about having pain in their abdomen. You need to know that low back pain can be a sign of a dissecting aortic aneurysm. Okay, so they could be complaining of back pain. But if they associate that with ripping or abdominal pain, we need to rule out a AAA. Okay, so let's get into a knee pain. A patient comes in, they've had a knee injury. Let's say they were playing basketball. And on the question, pay attention to whether or not they say that you do an anterior test or a posterior test, because your diagnosis will have to have the same thing. So if it's an anterior test or a posterior test, then that would be anterior ACL and PCL. Okay, so we're looking at torn ligaments if we're doing a drawer test. Okay, so if you are doing a drawer test, which is with the knee, okay, we're looking for ligaments. Know that if it's anterior, it's ACL. Posterior is PCL. Pay very close attention to that. So if you have a patient come in, and let's say that they are a typer, they are a receptionist, they're a stalker, lots of times a gamer, But they come in and they're holding their thumb. They're going to be very protective of this thumb. And they're like, it just really hurts right here. Okay, guys. So we should be thinking, okay, is it, you know, of course, looking at fractures or sprains. But if you push right down on this tendon, Finkelstein test, that is, and it's positive, they jerk back. It's a lot of pain. That's the tendon, okay? So you're looking at decurvin tendinosynovitis. So, Finkelstein test, know that one. And remember, Finkelstein, Frankenstein, decurvin, they're both weird. But that is the Finkelstein test, okay? Pushing down on that tendon. All right, so let's say that you have a patient again with, and you'll need to know this test. So you have a knee injury and you hear a click. Click. We're doing the McMurray test and it's a click. What are we looking at? Again, if you have instability of the knee, of course that's the answer. But what are we looking at when we do a McMurray test and we have a click? Hey, that's a meniscus tear. Click, click. Okay? So we got to refer that patient. When you have an ACL damage, and we talked about the drawer test, we actually do the Latchman as well, okay? So on the Latchman, you're looking for instability of knee. You're looking at ACL. It's the preferred test for exam, and it's more sensitive when you're dealing with the ACL is the Latchman. So that's the one they kind of focus on, not so much as the drawer test, but as far as the Latchman, because it is the most sensitive, it's the most indicative. So when you're dealing with soft tissue, though, remember, we're not going to be doing x-rays. CAT scans cost too much. So our test of choice is MRI. If you think there's a fracture, we do an x-ray. And again, we're looking at cost effectiveness, guys. If you have a patient who, in your case scenario, that talks about they're walking around and they have pain on the bottom of their feet and it feels like they're walking on, I don't know, it could be either one of them, but it feels like they're walking and it's kind of like on fire, so to speak. It's like it's pulling, it's burning. And these people, it doesn't happen when they're sitting up. It's just when they're walking and putting weight on it. So we need to be thinking of plantar fasciitis. These people we're going to treat with NSAIDs. They may need orthotics because remember they have inflammation underneath there. That's why it hurts when they walk on it. And we also can do some exercises with them to strengthen that. With the NSAIDs getting the inflammation down. And then we can also do some therapy. But the treatment of choice for plantar fasciitis, which is basically pain when walking, burning, does not occur when they are sitting up, is plantar fasciitis and NSAIDs. So what if you have a patient that is walking around and they feel like they're walking on pebbles? So the way that I remember this is pebbles, okay? Pebbles are round, so are neuromas, aka kind of like tumors. So if a patient is walking and it's between the third and fourth, and you, hint, may see that exactly in the case scenario, third and fourth metatarsal, you need to be thinking Morton's neuroma, okay? Refer to a podiatrist. So again, third and fourth metatarsals. So let's get into our osteoarthritis, which you will see on your exam can also be degenerative joint disease. Know that they are one and the same. Osteoarthritis is overuse. The way that I tell everybody is osteoarthritis is usually seen in the elderly or older. I don't like to think of my mom as elderly, but you know, she was a cook at a hospital for 41 years. She lifted all these heavy pans. So she has both nodes, the Burkhards and Herbidens, okay? That is osteoarthritis. It's overuse. They've used these so long that they have these disfigurations. And the way that you can remember this, if it asked you where the nodes would be, is just remember that B comes before H. So, 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 B co Yeah. So, H is distal, away. B is first, so it's proximal. So, sorry that kind of got like all twisted up. But actually I had somebody's name that I knew, and I can't say that, that I associate it with. But with osteoarthritis, this is like overuse, guys. This is years of youth. With these people, we need to look at DEXA scan. This is why we prefer that they have a DEXA scan, so we can get their T-score. If their T-score is less than 2.4, you know, we're going to be looking at that's like our cutoff is 2.4. And so we're looking at osteopenia or osteoporosis. Now, with osteopenia, we can stimulate osteoclasts. So of course we want to do some weight bearing exercises. So when you are talking to these patients and you're looking at your exam and you see these case scenarios, it may ask you which one of the following. Now remember, osteopenia, they can stimulate osteoclasts by weight bearing. Which exercise would you suggest? Okay, so this is be like, you know, especially if it's elderly, you know, weight bearing, they could do walks, you know, like 20-minute walk 3 times a week. I think it was one of them. And then with osteoporosis or arthritis, you know, we need to look at these people. Osteoporosis, they're brittle. They cannot stimulate osteoclasts, so we want to do non-weight bearing. So non-weight bearing would be like a bicycle or swimming. Those are good examples. So just look at your examples on your exam and see which one you would pick for each one. Remember, osteopenia, we can stimulate osteoclasts. Okay, so let's go on to RA. Now, rheumatoid arthritis is an autoimmune disorder. Okay, these are people, it involves multiple joints. Now, the difference between osteoarthritis and RA is, and this is the way you can remember it, is osteoarthritis is overuse. This is your older people. RA can occur in younger people, and it involves joints that are small and hands, or joints that are small and larger. They have a swan neck deformity. We will check their check for a rheumatoid factor, and their CRP and SED rate will be elevated. We're going to refer them to rheumatology because it is going to be something that they have got to be monitored for a long time. They could complain of fatigue and fever. It is one of the other joint diseases that have Burkitt's. Okay, but Bouchard's, some people say, I'm sorry. I guess it's just slang wherever you are, but no, for OA, osteoarthritis, is 2 letters, so both are present, both nodes are present. 2 letters, 2 nodes. With RA, rheumatoid, just think of rheumatoid. This is younger generations. They're not going to have that older stuff. They're going to have Bouchard's. Then with these patients, they may also end up complaining that, or they should be the ones complaining that they're symmetrical, meaning it's both sides. You know, both of their elbows hurt, both of their shoulders hurt, or both of their fingers hurt. Osteoarthritis can be in a single joint. It could be in any joint, but it's overuse. But RA can be, it is symmetrical. So that's the difference, symmetrical. Gout, let's talk about gout a little bit. You know, it's a uric acid buildup. What you also see with people who have a uric acid buildup is a thing called TOFI. You may see this on your exam. TOFI is white crystals, okay? It's that stuff you can squeeze and pop out, all right? So know that TOFI. But gout is uric acid buildup or uric crystal, so we do a uric acid level. Now, if we're treating someone with gout, we treat them with allopurinol. And that's just if we know that they have gout and they're just having some joint pain, and that their results are elevated. So, but let's say they have an acute attack. If it has been less than 4 weeks since you started allopurinol, you need to stop allopurinol and start colchicine. They can take 0.1 to 2, okay, until the inflammation goes down. If you have that patient and it's been more than a month, so more than 30 days, that allopurinol is already in there and it's already at a therapeutic level, so just add the colchicine to help them get that acute attack under control. We need to talk to them about, their dietary and lifestyle changes, trying to make sure that they don't take in a lot of salt that can cause inflammation, and monitor their levels. All right, this brings us to psychosocial, guys. Okay, so let's talk about it. Suicide risk. You need to know these. They may list them. There's just, multiple choice. They're going to list 4. They're going to say which one is not a suicide risk. Okay, so we're only going to go over which ones are. Okay, so suicide risk. Loss of spouse. You talk about these people that's been married for 30 and 40 years, and then all of a sudden their significant other's gone. They feel a loss. They don't want to be there. Or maybe they depended on that person. So loss of spouse. If they have a plan, if somebody even tells you that they have a plan, take that serious, okay? That is a suicide risk. If they have a history of attempting to commit suicide, if they have a family history of people who've committed suicide, if they have a diagnosis of depression or bipolar, those are high risk. Bipolar is very high risk because they have those manic phases and they have those depression phases, so they go in and out and they're very unstable. Terminal illness or uncontrolled pain. I can't tell you how many patients I've heard that, as a nurse practitioner, that they'd be laying in the bed and the pain is so unbearable that they just wish they died. Be very careful. We need to address their pain first off. But if it's terminal, we need to be looking at either hospice or, we need to put our patient first and get them some medicine. We need to address their depression as well. If a person has alcohol or drug abuse, and they're trying to get clean, and let's say that they've rebounded, these people are hopeless. They feel hopeless, I should say. They're not hopeless, they feel hopeless. So this is why they're at risk for depression, and for being unstable, and for risk of suicide. Divorce. How many have we seen on there that they lose their spouse, not to death, but to divorce? I mean, I had a friend in high school, and I went to school with him in high school, and just to make a long story short, it was on the news, and it was really sad because you wouldn't have known. He was an attorney. They had a good life, but she was going to leave him, and he killed her and then shot himself. So it's very sad, and it can happen. So if people are having marital problems, we need to make sure that we get them counseling and get them to someone they can talk to. It is important to note that females are higher risk than males. A lot of you probably didn't know that, but males are more successful in completing suicide. The reason being is this: women tend to just do overdoses or least lethal ways that can be reversed, or an attempt at suicide, or they may hesitate. But with a male, they use guns and knives, and they're more successful at completing the task. So those are the symptoms you need to be familiar with. So how do we treat depression? Okay, so we do a depression screening on them based on how often it happens and their score, how they're feeling. We can start them on medication. Now, for the elderly, of course, we want to do an MMSE. We do a mini mental to even see, is it dementia versus depression, or is it both? Acute serotonin syndrome is something that we have to be very familiar with. One of them is like, for instance, a Paxil. You have to be very careful that if they start a new medication and they start having muscle rigidity or confusion or tonic, like they're having tonic seizures or their neck is hyper-reflexing, we're going to have to change that medication. But unfortunately, first we're going to check their level, and it's going to show that the serotonin is high. And with these patients, we have to stop that medication, but unfortunately, we cannot start a new one for 2 weeks. So, of course, we're going to have to watch that patient. It's very serious. They can have seizures. It can cause death. And that is one of the reasons that we don't stop those medications abruptly, because they can cause seizures and death. So, with serotonin syndrome, and it's acute, it's right after putting them on a SSRI, they will have these symptoms, and it's because they have too much serotonin in their system. So we'll have to monitor them and change medication. Okay, so let's keep moving along with psychosocial. So we talked about geriatric depression scale, making sure that we do that. We also talked about medications. One of the ones that you'll need to know, actually there's 4 that you probably need to know for your exam, it's specifically reasons why. Zyprexa. We try not to use this because Zyprexa causes hyperglycemia. It also causes rapid weight gain, which increases the BMI. So, I mean, if you increase someone's BMI, and we know that a higher BMI can be a risk factor with diabetes. So we try to stay away from Zyprexa. But that is the 2 things that you're going to monitor. If you have to put them on medication, you have to watch their weight, and you have to watch them for diabetes type 2. Celexa. We try not to use this with men because they have a lot of sexual side effects. They may do well on it, but they might be sexually active, and they may say that everything's not working properly, and that's when you want to change that. But you need to try and stay away from it as much as possible because of the highest risk for it. Lexapro is the highest risk for serotonin syndrome, but it is the most effective, low dose too, so you just need to associate Lexapro with serotonin. Paxil is very, very bad. Try not to, this is for future use, try not to put your patients on it because it's one of those ones you do have to wean. Alcohol abuse, you need to know that the guidelines now state that 1 glass of wine by females is not an alcoholic. They can have a glass of wine a day and they're not considered an alcoholic. A male could have 2 beers a day and they're not considered an alcoholic. What you have to do is address CAGE, okay? And there are going to be some examples on the exam, and it's going to talk about which one would be higher risk to be an alcoholic, okay? And this is where you apply that CAGE guideline. And here's an example. C, I would like to drink less during the weekends. So this person's already saying that he's drinking too much, okay? A, my family thinks that I drink too much. So now we have family involvement. G, these are examples, okay, for CAGE. I feel bad that I don't spend as much time with my family because of drinking. So now it's affected their social environment. It's now affected their family life. And E, I have to drink in the morning to feel better to get through the day. If somebody has to have a drink in the morning, they're an alcoholic, okay? If somebody has told them they drink too much, they're probably an alcoholic. These are questions that you do on the CAGE questionnaire. You need to know that. But remember, when you're choosing which one would be high risk, that a woman can have a wine a day and not be an alcoholic, and a man can have 2 beers a day. That's the new guidelines. Okay, so this next one, when we go into psychosocial and alcohol abuse and just abuse in general, and my sister doesn't mind me talking about it because she's recovering, and that's great. So Wernicke-Korsakoff syndrome, my sister suffered. My sister was an alcoholic for 17 years, and it was really bad. And last year, she ended up in the hospital, swollen up, ascites, multi-system failure, comatose. We didn't think she was going to make it. She was as yellow could be. She had liver failure. She had ascites. She had Wernicke-Korsakoff syndrome. And it's from alcohol abuse. It's from using too much alcohol, and you shut your systems down. These people will be in ICU, and they're lucky if they do make it. And if they do make it, they will not be able to handle another binge drinking. These people need to go immediately, once stabilized and out of ICU, they have to go immediately to treatment. So, and these people have to be in Al-Anon for quite a while. But after they go through rehab. And I want to throw in there, this is when you're going to see, if you've ever seen somebody in the ER, or I actually seen it firsthand because of my sister, or if you see a patient in the ICU, they have what's called a banana bag. And this is one of those. This is to help protect their liver. This is high doses of multivitamins, and mainly specifically B1, which is thiamine. Now we're going to go into another illness, and this is anorexic nervosa. Okay, guys, so these are young patients. If they have a BMI less than 18, they are anorexic. These people are high risk for osteoporosis. I mean, think about it, they're malnutritioned. So their skin's going to be frail, their hair is going to be falling out, their bones are going to be brittle, they're going to have cardiac issues, they could have edema. So you could have somebody that's a anorexic, but then have peripheral edema, and the reason being for that is because they're malnutritioned, and their heart is affected because they don't have enough electrolytes. They're constantly vomiting, so they have intestinal issues, or they're just picking because with bulimia they binge eat, and you won't see that too much on there. I don't think anyone's ever had bulimia, but do know that it's binge eating and vomiting. These people see that they're always fat. Anorexia is the same thing, except for they rarely eat. You need to know they're high risk for no periods, like longer than 3 months, and that they can have osteoporosis. That can cause them to have spontaneous fractures. Stress fractures. All right, so let's go into the male reproductive system. That's about all that you need to know as far as with psychiatric. They typically leave a lot of that for mental health specialists, nurse practitioners, but you do need to know those for when we prescribe SSRIs, which is the drug of choice. I do need to make note that ADHD, the treatment of choice is a stimulant. So let's talk about males real quick. So priapism, which is a prolonged painful erection. You'll see these people come in and it'll be painful. They've taken, sometimes it just happens, and there's some kind of neurological thing there. But for the most part, this is what happens when these people take these like testosterone boosters or Viagra. So at the point that there's a painful prolonged erection, that's priapism. And we've got to get it taken care of because it's probably not very enjoyable. So SSRIs, we talked about that, but they can cause erectile dysfunction. So just remember that. A lot of times patients won't be compliant simply because that's what it causes. So make sure that when you're talking to your patients and you are prescribing this medication, that we are asking them, and you'll see this on your exam, that we're asking them about if it's causing any sexual problems. Testicular cancer, this is basically, you're going to see one testes larger than the other one. They could have back pain, feeling of heaviness. So if you see one testes bigger than the other and it's not inflammation, because that could be an infection, But if it's just swollen, then we need to be thinking ruling out testicular cancer. And you need to know that one of the high risk for that is cryptorchism. I think it's what it is. Yeah, that's when the testes don't descend. So prostate cancer. You know, these are patients that, and again, number 2, prostate cancer. Number 2, cancer risk or cancer fatality in men. Number 2. 1 being lung cancer we went over. Okay, so they complain of a back pain. They could have pain in their rectum. And they may just kind of complain that their urinary stream is a little depleted. But with BPH, the differential between prostate cancer and BPH is they'll complain of dribbling and stuff, but they don't necessarily have rectal pain or perianal pain. You want to look at, you know, of course, do a DRE, and then we need to feel and see if it's bulgy, if it's inflamed, if it's hard. Of course, you know, we don't do any kind of massages. And if it's tender, then we're looking at prostatitis. But if it's hard, we need to, and it's enlarged, then we need to refer them out. Testicular torsion, a clinical case, 14-year-old sudden severe testicular pain. We're talking they're in pain, okay? This is a medical emergency. Their reflex, where you touch the inside, the cremastic, where you touch the inside and it's supposed to kind of move their penis, it is absent. It's not there. Transillumination is the tool that we use. We can tell whether or not it's a hydrocele. We can also, which will transilluminate. Remember, we'll be able to see. With a varicelle, which is a bag of worms, it'll look like a bag of worms. It's technically just the intestines down in there. You won't be able to see through it, so it will not transilluminate. Okay, hydrocele. Think hydro water. You can see through some water. So hydrocele transilluminates. Benign prostate hypertrophy. It should, this is kind of like a classic case. You know, you got an older man, he complains of gradual, and it's been years. It's not just all of a sudden, but he has years of urinary symptoms, a weak bladder, nighttime, urination, nocturia, and sometimes he doesn't feel like he empties all the way. Okay, so, and with the prostate, you know, it's like a rubbery texture. So we're looking to see if it's enlarged. Okay, now if this patient has BPH and hypertension, you need to know for exam that we need to know Hytrin, and it's an alpha. Okay, it's an alpha adrenergic. You need to know either or, alpha adrenergic or Hytrin. If they don't have high blood pressure and it's just BPH, you know, then we could be doing some Flomax. But remember, if you have BPH plus hypertension, and it'll be in a case scenario, and you got to look at the PMI, guys. And if it says that you're going to start a antihypertensive, you need to know that if they have BPH, you cannot use anything else but Hytrin. Okay. If they don't want to take medication, remember they can take palmetto. It doesn't work for everybody, but I mean, it is an herb that they can use. So if somebody has acute prostatitis, let me tell you something. When you do your DRE, it's going to hurt them. It's going to be, you're going to feel that it's big. It's going to be tender. It's going to be boggy and warm. It's going to feel like there's something in there. Do not massage. Know this. You do not massage. Why do we not massage? We don't say, oh, let me feel it. We don't do that because we take a chance of letting that infection out. If we let that infection out, where could it go? It can make this patient septic. and this is probably somebody that's had a UTI for quite a while, just, you know, probably, I mean, it could be accompanied by UTI, but they've usually had UTIs. And then now when you do your DRE, it's painful and it's red and it's boggy and it's warm and it's tender, and you do not massage. For board purposes, if this patient is younger than 35, you need to look at an STD causing it, okay? And we treat them 10 days. Again, that's what we treat. Men are always a complicated UTI treated 10 days, all right? The treatment for that is ceftriaxone if we suspect that it's an STD, doxycycline. Let's go into the male or female. Okay, so breast cancer is often found in the latent stages. If you have a female who complains, or case scenario on the board that says that she went to a dermatologist and she was like, her nipples and areola were dry and peeling, and she did this medication and it helped a little bit, but it's still there, that should be an alert. Okay, scaly lesions on the areola, we need to be worrying about cancer. So that person we need to be referring. The skin lesion can be what's called Paget's disease, and it's chronic, meaning it won't go away. So just refer that patient out. Patients at high risk for breast cancer is family line history. Remember, we want to educate these patients about the BRCA exam or test, and you know, we have to remember that breast cancer, by testing these markers, we could save a life. So that's why for a breast cancer, we are proactive. This is why we order mammograms. This is when we have that nodule and we need to do an ultrasound. Anything on the exam that talks about BRCA, just remember it's family history. A positive means that they carry it. They carry the gene. A negative means that they don't. Let's talk about ovarian cancer. Okay, so this is usually it's postmenopausal. It don't necessarily have to be, but they will complain of like bloating, low pain, that comes and goes. It's not always there. It could be pelvic pain, low back pain, change in bowel habits. Because remember, I mean, as everything atrophies and the ovaries where they set, they can affect our and especially if there's a tumor there that's growing, it's putting pressure on our colon. So if it's putting pressure on our colon, there's a good possibility that they're having changes in their bowels. Okay, so we have to rule all this stuff out, especially if they're high risk. And you're going to know that by doing your complete history and physical. If they have a parent or a first-line sibling, first line and second line is actually considered high risk for ovarian cancer. We also need to know for the exam purposes with ovarian cancer, what do we know about ovarian cancer? You know, it's the leading cause of gynecological deaths. All right, you need to know that. Tanner stages. All right, guys, this is simple. They only care about 2, 3, and 4. All right. So 2, 3, and 4 with females, little girls, you know, people going through the puberty, you know, they get breast buds first, okay, and they're and then next they'll have their areola area, and then last they have both mounds, okay. So they have breast buds, and then they have breast buds with areola, and then they have, you know, Tanner stage 4 or 3 or 4. Is 2 mounds. For the purposes of the exam, if a mother brings a child in and she has all of this, she's worried that she hasn't started her period, and you check, what are you going to check? You're going to check for Tanner stage. What Tanner stage is she in? So you look, and let's say she has breast buds, just breast buds, Number 2. Okay. So that means within 1 to 2 years she'll start her period. Now, if you have a young person who has, let's say she's in Tanner stage 4, and she's got breasts and nipples, areola, she's got double mounds, then you need to be referring her out if she has not started her menstrual cycle. People, Tanner stage 2, 3, and 4 for male, you're looking at, they get that deep voice, and then their testes, and their penis gets longer, and then it gets longer and wider, and that's your 2, 3, and 4. It's basically it. They start with a deep voice, and then it gets longer and wider. Longer and wider. Okay, women with polycystic PCOS, polycystic ovarian syndrome. Remember, these people have high androgen levels, so they have facial hair, Hiroshima, something like that. Sorry, guys. And they are insulin resistant. They also have acne. Sometimes they're overweight. They have high blood pressure. They have a hard time getting pregnant. And these people, female patients may have multiple cysts. So remember, they're going to be high monitoring, so it's something that we would refer out to a gynecologist. Okay, some kind of tidbits that you need to know for your exam, just kind of hodgepodge stuff when it comes to female stuff, is you need to know that a palpable ovary is abnormal in a menopausal woman. So if you have a menopausal patient and you can palpate an ovary, you need to be worrying about cancer, okay? Cervical cancer. The USPSTF does not recommend testing before 21 years of age. We kind of went over that earlier. There are risk factors. Okay, I'm sorry. There are risk factors for cervical cancer. So anyone who smokes, who has had HPV, herpes, been exposed to DES as we get older, or they have contraceptive use. Those are high risk for cervical cancer that we have to address. If you are doing a pap smear test on a patient, what education would you give? You need to know this. You need to tell them that 1 to 2 days before the pap test, avoid douching. 1 to 2 days. Hint, hint. Vaginal foams, medicines, and intercourse. Okay, guys, so we're going to go into real quick about STDs. Let's talk about the whiff test. That's bacterial vaginosis. You know that is a fishy odor, all right? So if you have, it says whiff test positive, you need to be thinking bacterial vaginosis. And if you used my mnemonic for STDs, you will not miss any of these questions, guys. Cuties all get cuties to FU on. Suck, play, okay? Remember that mnemonic. So if you have someone with bacterial vaginosis, we're going to trip with flagell, all right? If they say fish-like odor, automatically, I don't care what kind of scenario it is, pull it out. Candida vaginosis, abnormal flora. Look at what these are talking about. Diabetics, they're high risk for UTIs because they're dumping that sugar. They're high risk for yeast because of this. So, those patients with, you'll look at any of the fungals, the meconazole, the clotrimazole, any of the OLEs, okay, ZOLE. Trick, Okay, this is green drainage, guys. Grayish-green drainage. It's going to be just like that, okay? Male partners may complain of dysuria. This is where we get into if they have UTI and they're less than 35, we need to be looking at STD. This is it right here. If you do an exam and there's green drainage with a strawberry cervix, it's still trick. Green drainage, guys. We treat that with Flagyl. Follow the mnemonic. Elderly patient or a postmenopausal woman and you're doing an assessment, she is sexually active. She complains of difficulty with intercourse. And you look and her vaginal area is atrophied. You would prescribe hormonal topical treatment, okay? Postmenopausal. You need to know that. Hint, hint. Okay, guys, we went into syphilis. Just remember that with syphilis, it's a painless ulcer, canker. If it's painless and it doesn't hurt, we need to worry, especially if you're doing an assessment and you see a painless canker. Be thinking syphilis. We do the RPR and the VDRL. That's our screening test. But they can be false positive with pregnancy, autoimmune disorders. So that's why we confirm it. Know this, because there can be a false positive, we confirm it with the FTA-ABS, okay? Chlamydia, again, test of cure 3 to 4 weeks after the antibiotic. Remember, we have to make sure this is gone. If you have a question that talks about contraceptives and if they miss 2 consecutive days, okay, they can take 2 pills the next 2 days to finish the cycle and get back on track and use condoms. Hint, hint. If somebody comes to you and she wants contraceptive, but she wants to get pregnant within the next 12 to 18 months, do not pick Depo-Provera, because what do we know? If people are on Depo-Provera, it takes up to a year after you stop taking the shot to get pregnant, okay? So you want to talk to these people about IUD or Planned Parenting. Okay, so pregnancy, we're running into this. Placenta abrupta. Okay, we've talked about this. This is just going straight into it. Placenta abrupta is painful bleeding, period. 3rd trimester, painful bleeding. You do your assessment and, let's see, yeah. You do your assessment and they're having uterine contractions. I want to make sure I didn't get ahead. And the cervix is affected. You need to send them to the hospital. This baby is going to probably be born C-section. Placenta previa, just know that it is bleeding. It is not painful. When you do your assessment, the cervix is closed. Okay? So these people will be on complete bed rest. HELP syndrome. Know this, guys. This is a rare condition from preeclampsia. It is hemolysis, elevated liver enzymes, low platelets. It happens in the 3rd trimester. Signs and symptoms, they'll have right upper quadrant or mid-epigastric pain. They'll have nausea and vomiting, and they may have thought that they just caught a virus. So we need to do all of those lab tests, okay? Check out the RBCs, look at the hemolysis, check out their liver enzymes, and check out their platelets. This is an emergency because anything that is out of whack like that is going to affect that baby and put that baby at risk. The flu vaccine is an inactivated virus. Therefore, it can be given during pregnancy. Need to know, especially just the positive signs of pregnancy. There are only 3. Okay, 3 to remember these. And then when you have the question on the exam and it talks about the others, you'll know that those are either presumptive or probable. Okay, so positive is what we see, what we hear. Okay, so we hear a heartbeat, We palpate a fundus, and we see the baby on ultrasound. That is probable or positive signs of pregnancy. There's only 3, so those are the ones you need to remember, okay? That is positive. Now, we go in real quickly, and this is the only reason why I go into and just say 1. Probable signs of pregnancy. You got to remember, some people have hydatiforms, and that's been with them all their life. I don't know if anyone knows what that is, but that's basically they've had a twin, and their body absorbed the twin, and so they have trouble getting pregnant, or their body will think at one point they are pregnant, and it's called a pseudo-pregnancy. And so that can also cause these females to think that they probably could be pregnant. So those are all probable. Now, presumptive is just what the patient tells you. I'm late on my period, my boobs are sore, I'm having cravings. It's just what they say. So, presumptive is just what they say. We presume. Probable, but we have to rule it out, of course, is, the softening of the uterus, the Goodell sign, Chadwick sign, things like that. And the 3 positives are what we diagnose and say, yeah, we see it, we feel it, we hear it. We hear the heartbeat, we feel the fundus, and we see the baby on the ultrasound. Okay? Know your fundal heights, that it's normal 2 up, 2 down. Okay? You'll have one question on there. 12 weeks is right at the umbilicus. If they're supposed to be 12 weeks and they're only measuring 9, we need to immediately do an ultrasound because we're worried that baby's not growing. Okay? If it's more, if they're supposed to be 12 weeks and they're measuring 15, we need to do an ultrasound because we need to worry about gestational diabetes. Okay? Let's go into, you're going to have one question regarding Nagel's rule, okay? The easiest way I can tell you is I subtract 3 months and add 7 days. RH factor. You may have a question in dealing with RH factor. So if you have a mom that's RH negative and baby is negative, they're okay. If you have a mother who is Rh negative and the baby is Rh positive, then we have to give the RhoGAM shot. The RhoGAM shot is, or if a mother's negative and she has a miscarriage, then she's pregnant, we give a RhoGAM shot at 28 weeks and then again after the baby's born. Breastfeeding mommies, if they have sore nipples, just give them support. Tell them to, just continue to try because that's kind of normal. Fetal alcohol syndrome, guys. You need to just take a look at a picture of this. These are little babies that come in, are born, and they have a small head. Their ears are not fully up where they were. They have a thin lip. Their eyes have the epicanthal folds. And you need to know what a fetal alcohol baby would look like. If a baby comes back in a couple of days and they have this crusting or drainage in their eyes, we need to be ruling out, especially if they're only 3 days old, 1 to 3 days old, or even a week after birth, that the mother had an STD. Okay, so we treat them and check mommy. Sudden infant death syndrome, they're higher risk if they're low weight, if the mother smoked, and if they lay them on their back. So we need to do education. Mongolia spots, guys. Don't mistaken this for bruising. A lot of times little babies will come in and we'll see them in the ER, urgent care. It might be the first time we see them and we're thinking, this kid's being beat. No. Let's get a history first, guys. Let's do some investigation. Know this for your exam, that Mongolian spots often are misconceptioned for bruising. Milia, that's a little white dots these little babies get when mommy comes in and says, oh my gosh, she's got all these white things. Just let's re-educate her that that's normal, okay? Cradle cap, seborrheic dermatitis. These are patients or babies that come in and they have that crud on the top of their head. You need to educate the mommy to use oil, let it sit there, and then use one of those soft brushes and get that off. I've seen babies over a year old and still have it, and I'm like, okay. The next thing we'll go into is fawn talus nevus. This is when you have a baby born and there's hair on the back of that. We need to rule out spina bifida. We need to worry about neural tube defects. So, of course, we're going to run all the tests on that baby. Let's see. Strabismus. Just know that if it's uncorrected after if it's uncorrected, and their vision should be perfect at or at 20/20 at 2 years of or 6 years of age, and they have strabismus, that we have to get them checked, because if not, then they can have permanent vision loss. But also know that if it just kind of does a couple beats, that's normal. That's a normal exam, okay? So if you're doing a school physical, or you have a scenario where they're talking about you're doing an eye exam and you're doing a school physical, and it has a few beats of strabismus, just know that that's normal. Okay, so for vaccinations, I'm not going to go into those real quick, but know my song. There's only one question, but just know it. Just, be familiar with it. Know that Hep B is the only injection given at birth. Also, you need to know just a couple milestones, like 2 months old. Just think of a little baby, they start cooing and barely holding their head up, because, for the first, seems like the month, they just sleep. 4 months, they start babbling. They smile. They'll move their hands to their face. 6 months, they start sitting up, and they start doing the Palmer grasp. Okay? Palmer grasp, sorry. Palmer. At 9 months, they play peekaboo, and they do pincer grasp. Know that. Hint, hint. 9 months. A 3-year-old can ride a tricycle. Know that. 4-year-old can draw a cross. Okay. Know that the bilirubin is breakdown product from old RBCs. And if it's elevated when a baby is born, it's from their fetal RBCs. And this can be due to conjugated bilirubin. Okay. It exceeds the liver's capacity. If they are jaundiced, of course, they're going to have phototherapy, sorry. And we're going to check their bilirubin level, okay? First line treatment is phototherapy, which we just reviewed. If they are stable, they can be discharged home if they're almost, to our normal levels that we like to see, and I'll tell you that real quick. And we will check them in 5 days. Okay, now coarctia of the aorta, that's where we check the blood pressure of both of their extremities, all right? And that's just basically how you need to know how you test for that. Developmental dysplasia of the hip. This is where the legs are not the same length, okay? We need to do the artilla. Remember, we bend their legs up and see if it clicks. Infant colic. You're going to have a question that's going to talk about a mother says a baby cries the same time every day. Know that as about the same time every day. Know that as colic, supportive therapy. If it does continue or they start vomiting, of course, we'll look for pyloric stenosis, and that's the olive-shaped mass. You need to know intussusception. Remember, it's a sausage-like. These babies, or these kids, toddlers, which is the highest risk age, will be curled up in a ball. They'll have belly pain. They'll be vomiting. And when you do your assessment, you're going to feel sausage-like. And basically, the intestines just go back into each other. Okay, so olive-shaped mass is pyloric stenosis, and a abdominal pain, and with assessment is a sausage-like appearance. That is intussusception, and that usually sometimes can be manipulated, but for the most part will need surgery. Okay, HPV vaccine, guys, we need to know that Gardasil. You need to know that the youngest age group for vaccination is 9 years. All right? 9 years. Hint, hint. Now, and they can have that until they're 26 years of age for females and 21 for males. But for the most part, just know that it can be given at the 9 years of age for both. And one thing that you need to know is going to be a random question. It's going to talk about emancipated minors. Okay, so emancipated minors is basically, one of them ends up being my son. He was 17 years old and graduated high school. Some of us graduate when we're 17. He decided to enlist in the military. Yes, of course it required my signature, but he was graduating and was going to go anyways. So, the moment that he became active duty military, he became an emancipated minor, all right? Or if they are legally married. Those are the only two. So you need to know that for your exam. Okay, we're going to wrap up with geriatrics, guys. This is my favorite one. You're going to have a lot of questions on this. So let's run through this. It's stuff that you see. We're almost done. I've kind of went over 4 hours, but it's okay. You guys are worth it. You will see a lot of geriatrics, and I'm going to talk about normal aging. And the reason why I'm going to talk about normal aging first is because you will have questions on your exam that will say the normal part of aging. Pick that up. I can't stress that enough. When you were talking about the elderly and they're asking you a question, please, please, please look for the words normal aging, okay? Because that is where this is going to come into play. All right, so let's get to it. Skin. Okay. Visualize your little elderly lady, thin skin, bump it, breaks open. So it's fragile. Why is it fragile? Because they don't have collagen anymore. We don't, as we get older, we don't have fat. We don't have collagen. Okay, sorry guys. So we have less fat and the collagen's not there, so it's frail and it's thin and it breaks. Okay, that is normal aging. Again, this is all normal aging. Nails. Their nails become thicker and brittle. You've seen these elderly patients, they're real thick and they got splits in them and they fall apart, they just fall off. Okay, that's normal aging for the nails. Eyes. Presbyopia. That's presbyopia. That's why they have to have reading glasses. Remember? That is normal aging. Presbycusis. Okay, this is why they turn the TV up loud, because normal speaking, high frequency noises, that's normal aging. It's gone. Okay? So for your exam, if you see that and it says which one of the examples is normal aging that you would suspect for hearing, you need to be thinking presbycusis, and it would be the TV elevated. Okay? So let's go to the heart. As they get older, it's worked for however many years they're alive. But normal aging of the heart, it gets long because, they don't have collagen, their skin's frail, their vitamins depleted, their renal system's depleted. Those are all normal. Renal system does deplete. So, of course, their absorption, because the GI decreases, of vitamins is not like it was. So, and the same thing with electrolytes. And these little people, they do not take in what they should because their stomachs get smaller. They don't feel like, and then they lose this weight. So with the heart, it gets longer and then it twists, and that's normal. Not pulsus paradoxus twist, but it'll twist just because of the decreasing in electrolytes in the tissue, the muscle tissue. And then from atherosclerosis and heart disease, we know that that's the number one mortality. So let's go into normal for the lungs. Now listen, they've been breathing in for years, okay? So their lung capacity is decreased. The amount of vital capacity of being able to hold in oxygen is decreased. The cilia are decreased. The function is decreased, okay? So this is one of those situations where when you see an elderly patient and you're doing your assessment and you listen and the lung sounds sound abnormal or absent, you know, they don't have the cilia moving that stuff. So we need to tell them, can you take a deep breath and cough? So they take a deep breath and cough, and then we listen again. And then you compare your assessment. And the latter in the elderly is okay. So even if you heard decreased lung sounds and then they cough and it clears and everything's okay, your latter is your assessment. The liver, guys, the liver is the only organ that is not affected by our age. It is rarely affected. This is why we choose medications that go first pass through the liver, is simply because it can withstand it. Now, of course, we don't want a bunch of medicine going through there, but it is one that we want versus renal because it atrophies. The creatinine clearance isn't working as well. It's like a filtering system. I mean, if you have a water filter and you've used it for 30 years, do you think it's still going to work like it did? No. But the liver gets off a little easy. It holds, first pass medications, but it's not affected unless they affect it, like alcohol abuse, things like that. But for the most part, think of the renal system as a normal part. When it doesn't filtrate right, it doesn't work right, okay? Because it's a cleaner, it's a buffer, it's a filtration system. That's why people go on dialysis when they have to, is because it filtrates their blood and gets rid of the waste. Well, the kidneys can't do that after many years, just like we would do with water. So, and I know that's kind of like a silly analogy, but it's true. I mean, that's what the filtration does for water. That's why it has to be replaced in big treatment plants too. So, again, musculoskeletal. As our body ages, normal aging of the bones and osteoporosis, of course we're going to lose height. I've already lost 2 inches. My mother has all the osteoarthritis and osteoporosis, and her T-score was pretty bad. So I had my DEXA scan, and I've lost 2 inches because of it. So you have to teach them about calcium and vitamin D, and we have to talk about exercises. But loss of height due to osteoporosis is normal, okay? GI, we just talked about that. Slower metabolism. Okay, so they've had this system that's constantly worked all this waste out. It's like the kidneys. Their mobility is not like it was. These intestines have been through the ringer. So they're going to have a slower metabolism, a slower motility. This is why they're high risk for GI bleeds, especially with NSAID use, because they're not pumping that thing through. It's some of that's just kind of sitting. And what do we know about, something that's acidic, like NSAIDs? It can burn a hole now. So, that's where we get into the normal aging, all right? Normal aging for a sexually active elderly patient, and there are some, is atrophy of the vagina, the labia, and so that's when you want to use the hormone. Now, one thing you will see is their immune system. So let's talk about that. So the reason that we go by CURB 65, another reason, is because these people don't always get a fever. Their immune system is depleted. They're older. They've been through the ringer. So what happens? They get septic really fast. And what is that symptom? Confusion. Okay? So they may not have a fever because of years of use. So we need to focus on the confusion, and that's where CURB 65 came into play with pneumonia, because you're not going to see a fever, and that's normal. But we do need to worry about sepsis with our elderly patients, and we need to make sure that we are addressing those. They're high risk for DVTs. Why? Because their blood is not circulating. Remember, I mean, they've got everything slowing down. Neurology, you know, they have this firing that it has slowed down. These people, that's why you see as they get older, they go into Alzheimer's and dementia and Parkinson's. Now remember, with Parkinson's, I'm going to go into that real quick. Parkinson's is a flat effect, like a mask, not really a flat effect, but a mask-like and shuffling gait. You're going to see that. Treatment is levodopa sentiment. Okay, you're going to see that on your exams to know that. Alzheimer's, they can be pleasant, but as it advances, they can have behaviors. Just know that with Alzheimer's, they lose the current information, but they can remember things from years ago, and we need to have a support system for them. Vascular dementia is those patients, not just dementia, but vascular dementia can be from alcohol-induced. It also can be from stroke. It can be from a traumatic brain injury. So just remember that with vascular, it's something that already occurred somewhere else that caused the dementia to occur. You also need to know that, just lost my train of thought. Let's see, Parkinson's, we went over, dementia, vascular dementia. Oh, Lewy body. Okay, know this one. Lewy body dementia. This is somebody who is totally with it one day, remembers everything. The next day, totally, they're not there. The next day, they're okay. So with Lewy body, these are people that have dementia that come in and out. Okay, it is the only one that they will remember current things and old things on different days. So one day they could be fine, the next day they're not. The next day they're back fine. So just, that's how you differentiate. Okay, we're going to wrap up this. We'll talk about a little bit of legal, ethical issues you could see on your exam for AANP and for the ANCC. Okay, benefits. It is what it says. Just let's break it down. It's the benefit. It is to our obligation to benefit the patient. Okay, so whether it be education on a new medication, encouraging to stop smoking, or their medication, it is what we are doing that's going to benefit. It's our obligation to benefit the patient. Okay. Non-malafence. Now, malafence is to, or like, malefit is to harm. Okay? And if it's non-malefit, then it's not to cause harm. So non-malafence is our obligation to avoid harm. All right. So let's take, for instance, somebody wants to be on, they have a history of a GI bleed, but, and ulcers, but she needs to be on something for osteoporosis, and she wants to be on biphosphates. Well, we can't do that because we know that that's going to put her at high risk for a GI bleed. So we do not prescribe it. Okay. So it is our obligation to avoid harm. Irregardless if the patient wants it, we don't do it because you're going to get sued if you do, whether it be from that patient or somebody else or their family member, because they're going to say, well, you knew you shouldn't prescribe it. Well, don't prescribe it. And you can use non-malafence. And that's simply your obligation to avoid harm. Okay, HIPAA, everybody knows this, Health Information Patient Accountability Act. You do need to know that a psychiatrist does not, or mental health provider does not have to show a patient their record. Hint, hint. Guardian ad litem. This is basically what you see when it has to do with an elderly or a vulnerable population like a child. One of the biggest ones is when the mother and father are going through a divorce and they are not putting the child's best interest at heart, like not making them go to school, letting them drink, letting them fail, drive without a license. This is when sometimes they'll get a guardian ad litem involved, and that person is the person who makes the decisions for the child. And it doesn't require a patient, or it doesn't require a mother or father. It can be if the court sees it or someone calls Child Protective Services. Power of attorney. This is somebody that a patient appoints, also called a guardian. Know that it can involve health and financial, and it must be notarized. Medicare Part A. This is your hospital payment. We need to know these because this is how we're going to get paid. Okay, Medicare Part A. Part A pays for hospital stay. I mean, you have your private insurances, but for the most part, Medicare Part A is what pays for hospitalization. You also need to know that Part B is like outpatient, is like therapies, home care. But we can bill Part A too for home care, just so you know. Part D is drugs. D for drugs. We need to know that because if they have a drug plan, we need to prescribe what their insurance will cover. Okay? Remember, we always want to put the patient first. You need to know too that nurse practitioners get their right to practice from their state legislature, which is BON, Board of Nursing. There are 2 types of malpractice you need to know. Claim-based malpractice is covered only if the NP is still enrolled with the same insurance at the time the claim is filed. Okay, that's claim-based. Now, occurrence type is a malpractice that covers a lawsuit that occurs in the future, but that nurse practitioner was covered when the occurrence or when the incident occurred. Okay, so that's occurrence type. And we're going to end up with this with 2 of the questions that I had for AANP was, and you should know as well for ANCC, although you will have to do a drag and drop type thing. But for AANP, you need to know that opinions are the least believable for research. It's just that. It's an opinion. Remember, we don't care what people think. Okay? I mean, we do. But I'm just saying, as an individual, you yourself, you need to just kind of look at it that way. Opinions are the least reliable. Meta is big. We're talking many researches or many people in the study. And that is the most beneficial for research. And I just want to end with, I know it's been a long haul. This went into 4 hours. It's probably going to be 2 segments. My apologies. But I wanted to make sure that you guys needed to know the main things for your exam. I'm here to help. I know I believe in you. You can watch this as many times as you want. And if you have any questions, you're more than welcome to send me a message. Thanks.